Thank you, Jesus. Thank you so much, Robin. We appreciate you. And Mr. Chris, who is in the background, thank you so much for that great worship. We thank you so much. And again, for those who do not know, that's Robin Wickman, and she has, you can see on her screen, she her songs, her albums they're under rawpraise.us. That's where you can find all her information. Is that correct, Robin?
Yeah, Raw Praise, RAW, rawpraise.us.
Okay, thank you so much. We appreciate you. Thank you for being here tonight. We thank you. Welcome you all to, thank you so much, Robin. We appreciate you.
Hallelujah, hallelujah. Glad to do it.
Okay, so thank you so much. Another moment where we're thankful to God to be here. We have our guest, most important guest speaker tonight. Dr. Haglind is here. She has been here since the beginning. We thank you for being here. Thank you for all the guests that have joined in tonight, and I'm sure you're ready with your questions. So for this very important moment. So I'll open with a word of prayer. Father, we thank you, we bless you, we honor you and magnify your name. We thank you for taking care of us all week long until this time. Oh God, we thank you for being here. Thank you even for Dr. Haglind, who has accepted to come here and bless us, oh God, with information. The word says that people perish for lack of knowledge, and we thank you because we are not perishing, because we will be informed and we will stay informed, and we'll be not only hearers but doers of what you ask us and tell us to do. We bless you for this session. We magnify your name.
Amen.
Again, thank you all for coming. We bless the Lord for being here. With us tonight, we have Dr. Elizabeth Haglind, and she's such a busy person. I asked her to send me her to send me information, her to tell me us all about herself a little bit. She didn't even have time to do that. But if you look her up, you'll be amazed. We have someone here who is board certified, professional association, board education from School of, I can't even start telling you all that. Let me tell you a little bit about, she's board certified in internal medicine, endocrinology, diabetes, and metabolism. So ladies, I hope you're ready with your questions on metabolism. And we thank you so much for coming. I told those that I've talked with that I've worked in the hospital for 20 years, and actually I've never really had a one-on-one conversation with an endocrinologist. They are busy people, they are not many, and so they stay busy, and they are most such after. So we welcome you tonight here, and I hope all of us will be ready to, to make the best use to be a blessing and to be blessed by Dr. Haglind. So I don't know whether you had anything to start with, Dr. Haglind, or do we just go ahead and get started with the questions?
Well, I apologize, Eva, for not sending you my CV. It's actually a long, silly piece of paper. I think we all achieve what we can because God has given us the opportunity. God opened the right doors at the right time. And some of us are on one side of the fence, and others may be on a different side of the fence, but it's all okay because it's all part of God's kingdom. So let me just bring everyone up to speed. I did my medical school in India, and I started I did my residency in internal medicine, and I was teaching at a medical college hospital. And then I moved to England and did got my membership of the Royal College, again, did my internal medicine once again, because every time you move from one country to another, you have to retrain. So then I did internal medicine again in the UK, and then started my endocrine fellowship and came to the US to do research, and then decided to stay back in the US. So I did my internal medicine residency third time, and then did my endocrine fellowship again in the US,
Wow.
and then graduated. So I am in private practice right now. I used to do hospital practice and see hospital patients, but now I just do outpatient practice. So Eva is doing an amazing ministry here, wanting to educate people. And I loved your prayer, Eva, where you just ask God that we are going to use knowledge so that we don't perish. And I'm humbled to be able to share what God has revealed about our body, metabolism, and where we are. We are only scratching the surface of the whole thing. So I'm here happy to answer questions. And, you know, diabetes, endocrinology, and metabolism is such a wide, big field that I wouldn't even know where to start if I had to prepare anything. So I'm here at your disposal. Feel free to ask me questions. I will be honest with what I can and cannot, answer. Some people interpret metabolism differently. And so I'm ready to take questions. So over to
Great.
everybody here. Yeah.
Lord, good. All right. Who will go first? Who wants to go first?
Hey,
Unmute
everyone.
yourself. Okay.
Hi, everyone. My name is Dr. Wardell. I practiced pharmacy for about 16 years, and now I'm a minister, and I'm very much into holistic medicine. And then I went on into public health. And so my question for you, doctor, you have a fantastic resume, is how difficult and how do you move into that realm of educating? I know you said you're in the outpatient sector, people, within the faith-based community who rely so much on holistic medicine. I'm not going to say that, as a pharmacist, that I don't believe that people should not take their insulin and things like that. And of course, I'm not an advocate of metformin because of all the side effects and things like that. But how do you, what suggestions would you give us in terms of educating those marginalized populations about diabetes and how to come across to them and let them know the impact of that on their health?
Yeah,
I think that was a couple of questions.
Yeah, there's a lot in there that you managed to pack in. How do you educate the marginalized? I mean, diabetes is a direct outcome of I'm talking about type 2 diabetes. I'm not talking about type 1 diabetes. So for those who are less familiar, we have type 1 diabetes, which happens more so in children, adolescents. That's usually the stereotypical kind of patient. They have insulin deficiency. They need to be started on insulin right away. Patients who have type 2 diabetes, it comes on later in life. And there is an element called insulin resistance, which often develops concomitant with weight gain. So I think that the starting point is to realize, what does gaining weight do to the body, and how does it cause a resistance to the insulin that our body is already making? So we have insulin. The pancreas is probably making a little bit more insulin, but the efficacy of the insulin at the level of the tissues is decreased because of this element of insulin resistance. And that kind of sets the stage for diabetes. So to understand what weight does, and then to be able to be proactive about what are the measures we can take to prevent weight gain, how do we eat healthy, how do we count carbohydrates, how do we limit the carbohydrate intake, how do we exercise, what is the recommendation for aerobic activity, for weight lifting weights, that becomes foundational. to be honest, it's easier said than done. And there are so many barriers that comes in the way. So every patient is unique. Every patient is different. Every patient's journey of life itself is different. So to be able to just meet with patients where they are in the journey, to understand what their challenges are, that's where I have to start. It's not pushing pills, but it's actually starting there. It's interesting that we talk about holistic medicine, but you know, every patient has their own opinion and has their own ideas on how they want to approach this lifestyle modification. So to invite them, to engage them in how they think they can navigate their health, that's important. Because if you're not able to work in partnership, it's not the patient's responsibility, neither is it the doctor's responsibility. It's like a partnership. So to understand, hey, where are you in this journey? What are your thoughts and how can I come along? And then take it from there.
Thank you.
Great question and great answer. Next, just unmute yourself. Oh, Dr. Ashera, if you have another question, you're free to go.
Honestly, I really do. I really do.
Go ahead.
What role do you think the social determinants of health play in the stage of diabetes?
Huge.
With the outcomes, and you know, in terms of from a public health practitioner, how do we engage as healthcare professionals to get that to come across and to help patients with those social determinants of health and help the healthcare sector understand just the role of the social determinants of health with the stage of diabetes?
Great question. The social determinants of health are vital. They're just vital. There's a huge role that is played at so many different levels, at the level of education, literacy, understanding, poverty, exposure to just the social norms within the home, within the community, and how that influences lifestyle options and choices we make. The amount of stress within a home, the ability to be able to even focus on your food or what you need to do or balance your diet when there are maybe 101 other things that may be going on in someone's life. They are all huge. And if we were to talk about, let's just take a simple example. I walk into churches, and as you leave the church, you have these big racks of bread that is donated by Paneras, or some of these, and there are bread and bagels just sitting in the church for people to take and go away. And they're just high carb foods, but they're just available free. They're high carb and processed foods that are just given freely to people. I wonder how many of them pick up the bread because it's cheap, it's available, and it's free. But how many of them really pause and think, okay, what is this going to do? What is this going to do to me, or what is it going to do to the rest of my family? I think women have a huge role in understanding what it takes to create a healthy home and a healthy family, because they're the ones who are usually in charge of the kitchen and what is fed to the children. Unfortunately, I think, when we grow up, our palates get used to what we have been fed as a child. I grew up in India, back in the 1960s, 1970s. I grew up on rice and I ate rice all my life. But today I cannot afford to eat rice. But it's a big challenge when your palate is already adjusted to a certain food to then ask that person, you can't have that anymore. That's a big change. So what happens in childhood to a little one, the way we program their diet, their food, goes into the choices they make when they grow up. And so whatever are the determinants that decide how is a child raised, what is the family atmosphere, what is the food they get to eat, where is the source of comfort for that child, and what kind of food they take is going to determine what choices they make later on in life. So does education play a role in that? Absolutely. Does financial status, does income, does poverty play a role? Absolutely. Is there a role for stress? Big time. Yeah, so it's very complex, it's multi-layered, and they all play a huge role in what's going on. And I think there are multiple avenues for intervention in the society. Unfortunately, as an endocrinologist, I see the tip of the iceberg. I don't see the big load, the burden, that really goes to primary care. And you raise an interesting point. I wonder what are the community initiatives that are going on that are ethnically sensitive, and will be able to address some of the challenges that are faced in the community. I'm not aware.
Yeah, I'm sorry for cutting you off. I think that's huge with the community initiatives, and I applaud you for saying that, because it's everyone's responsibility. Mm-hmm. It's not just the endocrinologist, but it's everyone. It's multi-layered, but it's everyone's responsibility. And that education is huge. I just want to add that a little bit. But I've always wondered, like with practitioners, do they understand exactly the social determinants of health, the role that it is playing for that patient and what they're doing? And I thank you for answering your question, but I do agree with you that there needs to be more community initiatives and grassroots organizations like myself, Emmanuel Health and Social Services, Grace Ministries. That's an avenue for us to get out there and start doing that education and addressing some of those community initiatives. Thank you so much for answering my question.
Yeah, if I could just piggyback on that comment, two things that I face personally in my clinic. One is the cost of insulin, right? Cost of diabetic medications. There are all these new medications on the market. There's GLP-1 agent, there is this and there's that, but the cost is so high that it becomes very prohibitive to take those steps. It's easy to prescribe when you have a commercial insurance and everything is covered and it's hunky-dory, or you have a big balance in your health savings account. But what about those patients who have a high deductible plan and they are hoping that they don't have to spend that deductible, and they can live off it? But when a health challenge comes, it becomes a big burden to these patients. And I think at that point, you can't help but think, wow, prevention is better than cure. And so educate so that the next generation is in a better shape, makes better choices. And then, there are still, from a holistic perspective, as you would say, it would still go back to diet and exercise and do the best that you can at that level. On the other hand, I also do see that there are so many barriers to being able to make that change. To just give a simple example, I remember a diabetic patient, he would come to see me and nothing would change. He would come to see me, 3 months later, the same A1C, and nothing has changed. And one day I just paused and something made me just ask him, how is your son doing? I knew his son was in Iraq and had been deployed during the war. And he just perked up and his eyes just opened up and he started talking about his son and when was the last time he heard from his son, and that his son is in Iraq and he's so worried about his son. And I just let him talk. I didn't do anything. I just let him talk. And then after he finished talking, he asked me, so Dr. Haglind, what do you think I should do for my diabetes? And I told him the same thing I had told him like every single time in the past. I didn't tell him anything new. But suddenly he just took that information in. He just felt like he had connected with me at a human level, and not just as a teacher and student or doctor and a patient, but he just felt like, okay, here's someone with a heart of compassion who was willing to ask about his son. And I think as a physician, I have learned lessons along the way that allows for that connection. They say that a patient doesn't care for what the doctor has to say unless they feel that the doctor actually cares for who they are. And so it's, I think that dynamic is also important as we minister to our patients. So it doesn't sound like you got to do this, but it's really understanding where they're coming from. Yeah.
Wow, wow, wow. Amen. Another question, next question. Does anyone has a question? This was a Q&A. Or you can type your question directly to the doctor. But while they're thinking, maybe I can ask, and actually, some of my questions, you already answered it already with what you're talking about, our culture and our foods, the exercise and types of diabetes. I was gonna ask maybe to talk about a little bit about, first of all, I don't know whether estrogen replacement is something that, okay. You tell us something about estrogen replacement.
Okay. Well, it's not something that I do routinely. Usually it's done by the OBGYNs. And estrogen replacement, I'll tell you the little snapshot that I know. In a postmenopausal woman, estrogen replacement can be considered for like within the first 5 years after menopause, and it is used for hot flashes that is not responding to any other treatment. Estrogen is not the first line treatment, but sometimes women use it for they use it for other reasons. They use it for there can be vaginal dryness, there can be just aging, and they want to prevent aging from happening, so they take estrogen. Again, it's recommended for the first 5 years, and then you taper and you stop. The truth is that God made our body to have menopause at a certain age, and allowing the tissues to be continuously stimulated with estrogen, even well beyond those initial 5 years after menopause, is probably going to create more harm than good. So we say, you can use estrogen replacement about 5 years and then stop. From an endocrine perspective, we talk about bone density and the decline in bone density that happens. So when the estrogen levels drop in someone who is menopausal, the bone density also starts going down. So will estrogen replacement then prevent the loss of bone density? Probably not. So bone density can decline even with estrogen replacement. So that's something to kind of just kind of understand. So doing the calcium and vitamin D, especially in that perimenopausal age, and making sure we're not calcium and vitamin D deficient, will help to protect the bones.
Okay, thank you so much.
Can I make a comment really quick about what you said, Doctor, and on what you said, Eva? But then again, here we go again with the exercise, with the bone density and things like that. The importance, there's that holistic role again, because wouldn't exercise protect if we could help those communities understand the importance of walking and the importance of, making sure that you have those vitamin D supplements and things like that, and eating correctly. Again, there it is, helping with the bone density. Am I correct?
Yep. So the kind of exercise that really helps bone density is weight-bearing exercise. So just walking is the best weight-bearing exercise. Holding a couple pound weights in each hand and walking, giving that little bit of extra skeletal load helps the bone. The biking does not really improve bone density a lot because your feet are off the ground, so it's not a weight-bearing exercise. Likewise, swimming, you're kind of held up by the buoyancy of the water, and so it's not really weight-bearing. So bicycling, swimming are not really the best weight-bearing exercises, but walking is an excellent weight-bearing exercise. There is also a vibration device where it's a very expensive device. It's there in some gyms, very expensive gyms will have it. It's like a plate, and you get to stand on the plate and you hold the handle on top, and the base then starts vibrating when you press the button. And the vibration, you have to balance your legs so that you don't fall off the plate. And within a minute, your muscles are just tired because all your muscles are contracting so that you don't fall off the thing. And after a minute, you're like, can you just stop? Because I'm really tired. But that really gives a lot of multiple muscle firing happens. And when the muscles fire from the tendons, it kind of pulls the periosteum of the bone and helps the bone remodeling to happen. So that's an exercise that really studies have shown an improvement in bone density. So weight-bearing exercise, hold a couple pounds, walk regularly. And if you have access to stand on that vibration plate, a few times a week, that would be great.
Oh, wow. Never heard of that. Okay.
Yeah, so those exercises are not necessarily weight loss driven exercises. They are very specific for bone density. For weight loss, the recommendation is to do aerobic activity 30 minutes a day, 5 days a week is a minimum, and do weights for at least 2 days a week.
Oh, wow. Okay. All right. Thank you so much. We are learning a lot here. Any other questions?
Yes, I do. This is Anastasia. I have a question, doctor. About 3 years ago, I was told I'm pre-diabetic, and the doctor recommended losing weight, exercise, and I did both. And I lost a lot of weight, which unfortunately I've gained back. I guess we are all excusing ourselves with COVID weight. And my A1C did not improve, or it improved just slightly. So what am I doing wrong, or what do I need to do more?
Yeah, so weight is a funny thing, okay? I've come to believe over time that it's almost like the weight set point we have in our brain changes as we gain weight. So if we reach a peak weight of say 300 pounds in our lifetime, it's almost like the hypothalamus in the brain has set itself to that weight. Now you may lose weight, lose 100 pounds, go through gastric bypass surgery, do anything as drastic as you want and get that 100, 120 pounds off, and you come down to a weight of 180, it's like it's so hard to maintain the weight at the lower point. And there's always like a slow weight regain that happens progressively towards that original weight. So there's something that the more we kind of expand our body, it's almost like we are resetting the overall weight, and it's very hard to lose weight and to keep it off. So people lose weight, but the biggest challenge is to keep it off. So I think what we understand today about that weight regain part you're talking about is limited. I think there's a lot more information that's going to come out about gut hormones, about the satiety hormones, about leptin, and we only know a part right now. So I always tell my patients that, this is the best that you can do. So exercise, watching your carb intake and being diligent about it, that is the best that you can do. And if your thresholds for A1C or blood glucose are continuing to climb, then we may have to think about medication on top of what you're doing. But there comes a ceiling where I don't, there is a ceiling for sure. And it's not that we will all be successful in reversing and maintaining that weight loss. There are a lot of patients who do manage to keep that weight loss, manage to keep their weight stable without a regain, but it's a few. The patients who do that are less than the large number of patients who manage to regain. So to answer your specific question in your situation, I would review your diet with a fine-tooth comb and see every area that you can improve upon. I don't recommend ketogenic diets, but limiting carbohydrates to less than 30 grams with each meal and having no more than a total of 100 grams per day would be a starting point. And then choose, instead of using processed carbohydrate, go with natural carbohydrates, go with fruits and vegetable sources of carbohydrate, and have protein with every meal, and keep doing that. There's a lot of talk about intermittent fasting, and I think it works for a lot of patients. I believe that after when we hit 30, we probably want to completely eliminate snacks and have 3 clean meals. And when we hit 40, we probably need to go down to 2 meals and maybe a small snack. And when we hit 50, we probably need to be down to 2 meals a day. And maybe when we get to 60, 65, I think our body's metabolism can only handle about 1 meal a day. And if we don't make these proactive changes every decade, we're probably going to keep gaining weight and wonder why we are not losing.
So thank you. And so I have 2 questions. You said you'd not recommend a ketogenic diet. Why? When I lost weight, I did the keto diet, and then I have a slow metabolism, and it got worse during that time. I would also like to know what I would do to improve my metabolism.
So first of all, I don't recommend ketogenic diet because I don't know people who are able to maintain that diet.
Okay.
Okay, so you lose a lot of weight, and then when you gain the weight back because you're not able to maintain the ketogenic diet, it's a very restrictive diet. People just gain the weight and they go beyond their baseline weight. So there are some people who have started ketogenic diet very young and they're able to maintain it and they're in the movement and they go, but it's hard. It's hard. And so that's the reason why I tell my patients, I'm not looking for a weight loss like this. If your graph goes down, you are probably going to have a rebound graph that will go the other way, because that's how the brain will start thinking, oh God, the body is dying. We're losing weight. Now we've got to stop this weight loss and we've got to get the body back healthy because the body has already been used to a different weight, right? So we see, so that drastic weight loss is rarely sustainable. So that's the reason why I don't recommend these extreme diets, because when they come off the keto diet, boom, they just regain all that weight back. I always tell my patients, the focus on weight loss can only be so much. You eat healthy, you exercise regularly. Don't exercise that you start hurting your joints. Be smart about your exercise. Be aware of what is the weight that you're going to pound on your joints as you exercise. Eat right, exercise right, and keep that going. The worst thing people do is, I've been doing all this and nothing works. So you know what? I'm going to give it up and I'm going to do whatever I want. Now it's a slippery slope and they go down that slope very fast. No, it's like we've gotten to a point where we're not going to do that. It's like it's like salvation. It's like accepting Christ, right? Just accepting Christ is not enough. Then begins a journey. And it's a long journey as we continue with our process of sanctification. And so it's just like that. Here we go. I've decided to give away my old habits. And I'm going to start new, but I'm not going to turn over a new leaf tomorrow. It's a process, and I'm going to keep enduring and keep going through.
All right. What about the slow metabolism? What can I do about that?
Okay, so when you say metabolism, okay, I have a slow metabolism. Who has a fast metabolism? Who doesn't have? We all have slow metabolism, right? The question is, how do you? So there's no way to measure metabolism, right? There's no blood test to measure metabolism. People
So
then
maybe the question is, how do I improve it?
By eating right and exercising. That's it. There is nothing else you can do. Thyroid hormone kind of controls metabolism, but we're going into a completely different field altogether. I have a lot of patients who come and tell me, oh, I can't lose weight. I need thyroid hormone. Thyroid hormone is not going to, I have to make you toxic. I have to make you sick on the thyroid hormone to make you lose some weight. And you will end up having side effects related to the heart if I take you to that toxic level. So there is very little we can do to manipulate metabolism. When we talk about metabolism, it's like saying, I'm trying to find an analogy that I'm really not able to pick here, but we have to work with the body that we have, and we have to run, we have to exercise, we have to move, we have to eat healthy, and we have to start cleaning our body from the inside out. When we do intermittent fasting and give like 12 hours or 10 to 12 hours without any meal, we allow all the toxic waste in our body to be rid before we put another meal into our body. So, sleeping well, eating right, exercising, eating 2 meals within like an 8-hour period at the most, and then not eating the rest of the time, staying hydrated, drinking plenty of water, you're doing the best for your metabolism. And then you know what? Take your mind off your weight. Just let it go. Just let it go. I have women who get up in the morning, they go to the gym and they exercise. Then they go to work and they finish work and they go back to the gym and they exercise and they eat like a bird. And they're sitting in my office. They are so stressed because they haven't lost a pound. And I'm like, okay, if you're so stressed, your stress hormones are through the roof, which will not help you to lose the weight.
Okay.
So there comes a point where I think we all have to make peace with our weight. When I say that, I don't mean that you shouldn't watch your weight or that you should stop doing the right things. No, when I say you make peace, it means that God does not look at our BMI. Amen to that. Okay, let's not forget that we are made in his image, and he looks at our heart, he looks at our soul, and everything, every choice that we make, every food that we eat, and every exercise that we do, we're not doing it for our bodily, we're doing it so that we have one more day to worship him, one more day to co-labor with Christ to bring his ministry on earth. And so we carry this body of ours with a certain amount of humility and with a certain amount of peace that, okay, I'm going to make peace with what I have, but I'm going to do the best that I can and leave the rest to God. Because, I think women have bought into the Barbie doll complex. There's not a single woman who has told me I'm happy with my weight. Someone with a BMI of 35 will say the same thing that someone who has a BMI of 20. Even the woman who has a BMI of 20 says, I can't get that last 3 pounds off. And this person is just, obsessed with that last 3 pounds. So it's like, where do we, right? Where do we call it a day? And where do we say, thank God for a father who looks at his daughters, not based on their BMI, and do the right thing and then let it go.
My. Wow, that is good. If we had to stop there, I would say that is awesome. That God does not look at our BMI. I like that.
That was beautiful. Just
That's good. It is beautiful. Hallelujah. All right, we have another question.
My
I
daughter,
think there was a question that came in the chat. Is it possible to reverse diabetes? I know your daughter asked that question. So yes, it is possible to reverse diabetes. It depends on where is diabetes in the trajectory. Again, we're talking about type 2 diabetes. So in the first phase, to understand that as we gain weight, there is that insulin resistance. When there is insulin resistance, the pancreas tries to make a little bit more insulin to overcome that resistance. So you have this phase where your blood glucose is still normal, but your insulin level is high. Your blood glucose is still normal. So that is not diabetes yet. And then if the weight gain continues, then the pancreas keeps making more and more insulin, but it's not enough to keep the blood glucose stable because the resistance is also high. Now, at that point, the blood glucose level starts climbing up and you start seeing pre-diabetes and then early diabetes. I believe that with weight loss, the pre-diabetes and early diabetes is reversible. But if things kind of keep moving forward, the pancreas gets exhausted. It cannot compensate anymore with more and more insulin. And then there comes a time where the pancreatic cells kind of drop making the insulin. It's like the pancreas is like, I can't do this no more. I've given you everything I've got. And when insulin deficiency sets in, then you kind of almost reach, okay, here's when you start somebody on insulin and it's hard to turn the curve at that point. So yes, it's reversible, but it depends on where in the trajectory of diabetes you're trying to intervene. So if you go to somebody who's already on insulin and taking a large amount of insulin, and then you tell them, I'm going to reverse your diabetes, stop the medication, that may not quite work out.
Great.
So
Thank you.
Another question. So if somebody is taking diabetes medicine and then they keep measuring their blood sugar and it's gotten back to normal for a month, 2, 3, 4 months, do they still need to keep taking the medication or they just need to go back to the doctor and review that?
Yeah, I think it would be helpful to have a very specific example in this situation. So if the medication is helping that person to keep the blood glucose under control, unless there is an underlying change in the person's lifestyle big time,
okay,
if you don't take care of the foundational problems and you just simply took the medication, A1C came down, and then you took off the medication, you're going to go right back to where you were. But if along with the medication, so patients tell me, oh, doctor, the last 3 months, my so-and-so, my husband had an operation. I couldn't watch my diet. I'm this, but I don't want to start medication. Give me another 3 more months and I will clean up my act. And I tell you my A1C is going to get better. This is what I tell them. I tell them, the longer you let your A1C stay high and you allow your tissues to be exposed to the high blood glucose levels, you're just going to end up getting the complications because the glucose level is toxic. That high glucose is toxic to the lining of the blood vessels. So you want to bring down the glucose in your blood. So take the medication, eat healthy, exercise, and then once you get that new habit into your lifestyle, we'll stop the medication. But if you don't put that foundational pieces into place and just say, I took the medication, now I'm better, so I'm just going to stop the medication, that's not going to help.
Okay.
So there have been situations where I have backed off on the medications, and I know one gentleman, I still remember him. He started running and he became one of those guys who would, I live in Minnesota. I don't know where you live, but here's the winters are absolutely cruel. And even in the winter, he would wear his jacket and he would go out for a little jog twice a day. And he got off all his medications. everything. He got off all his medications. So yes, you know, he was, I don't know, maybe his A1C was as much as about 8 or so, 8.5 maybe, but he was able to reverse it and he did well and he didn't need to see me anymore.
Great. Any other person with a question?
Eva, this is Mary.
Welcome, Mary.
Thank you. I have my mom and a few other people in our family who have diabetes. And I've quite often had people talk about, is it called Metformin, the one they take for diabetes?
Mm-hmm. Mm-hmm.
Yes.
Yeah.
And quite a number of people say this has a lot of side effects. I don't know your opinion about that. And is there any other medication you recommend besides that? Or
Yeah, so all medications have side effects, right? I think if we read the pamphlet on Tylenol, we won't be taking Tylenol either. So yes, metformin has side effects, but you know, I called metformin, and there's another medication. I call it as a known devil, in the sense that we have used it long enough that we know what it can do and we know what it cannot do. So the side effects of metformin are very simple. They're like belching, bloating, diarrhea. You know, it's all this GI upset and can be pretty obnoxious when if those side effects develop. It's not the life-threatening side effect of metformin is very, very uncommon. I have read about lactic acidosis in medical school, and we had to write, multiple choice questions in exams. They would often ask about lactic acidosis and metformin. I've practiced endocrinology for now close to 26, 27 years. I have not seen a single case of lactic acidosis with metformin therapy. We don't use metformin in patients who have renal issues. Now, people say, oh, I took metformin and that's why my kidneys kind of got, most of the time it's because their diabetes was so badly controlled that they have developed a kidney disease, and then we have to stop the metformin because now they can no longer continue the metformin. So the question is, is metformin going to cause more harm, or is it the untreated diabetes that is going to cause more harm? And that's a question that each patient will have to answer and make a decision for themselves as to whether they want to take the metformin or not.
Thank you so much.
So in that case, if I may, let's add on that. So would you recommend blood work? Like, blood work when someone is taking metformin, or just a regular once a year lab work is enough?
Once a year lab work is enough, because in patients who have diabetes and who are on metformin, once a year checking the creatinine kidney function is all that they need, unless there is an abnormality with the creatinine to begin with. Then of course it needs monitoring at a closer look. But if they have a normal creatinine, you don't have to keep checking it every 3 months or whatever. Once a year check would be enough.
Any other questions?
I have a question. I have a question for the doctor. One last question, doctor. Just to piggyback off of what you said about the renal failure with the metformin. I like the way that you described that about the devil with metformin. Is very tricky. But do you see more people with the renal failure with people with hypertension?
Yes. Yes,
that's what
absolutely.
Okay.
Absolutely. Hypertension along with diabetes. And now we have also recognized that obesity is an independent risk factor for renal damage. So we are seeing patients who have obesity, no diabetes, no hypertension, they're going into renal failure. Okay. So now you put diabetes, hypertension, and obesity together, you have a very high risk for renal failure. Yes. So in a diabetic, we start addressing the weight right away when we get somebody with diabetes, but then keeping a close eye on their blood pressure, checking the urine for protein leaks. So we do urine for microalbumin once a year, and then using the medications that can prevent a protein leak if that is there is very important. But yes, hypertension is a very, very big risk factor for development of kidney disease.
I mean, with the when you're using that metformin, like, would you say that why the metformin gets such a bad rap with the renal failure? Because those patients also, and maybe I need to look at the literature a little bit more, but with that hypertension, patients that's on metformin, is that why the metformin gets such a bad rap? Because those patients, they do have renal failure already. I mean, excuse me, they already have hypertension already. And so then that's like already a comorbidity, which like makes it looks like, oh, okay, it's this metformin that's doing that.
Yeah, I'm not aware of metformin and hypertension being, creating an escalated comorbidity or creating an escalation of risk factor towards kidney disease. I have not really heard that combo. I think hypertension with diabetes and obesity makes the groundwork for renal damage. And then once a renal damage sets in, then, we start pulling off the metformin. The other situation where we take off the metformin is patients who are going to have contrast when they're in the hospital, and they're going to have contrast for an angiogram or a CT scan, and you're concerned about contrast-related nephropathy, then you hold off the metformin for 48 hours before someone goes in for a contrast. But I'm not aware of hypertension and metformin as a combo that is bad.
Thank you so much.
I did see Halle Berry's name come up in the chat. Now, can someone educate me about that celebrity, that gorgeous celebrity? What's up with her diabetes? I have no idea. Does she have type 1? I would think she's
type 1. I'm not for sure if it's type 1 or type 2, but I think it's type 1. And
yeah, she's a super thin, tall, beautiful, gorgeous woman. I would think she's more a type 1, and the entire conversation we had this evening is more relevant to type 2 and not to type 1. We do not put metformin in type 1 diabetic. So whoever raised that question, just to clarify that.
My daughter wanted to know, because, the media never says if she has type 1 or type 2, but they always say that she doesn't take insulin, and it's so well controlled, and she's doing very well on it. And so that was what she was wanting to know, if it can be reversed just by eating just the way that Halle Berry did.
Oh, wow. That's okay. So there are other conditions of diabetes. Okay, we talked about type 1 and we talked about type 2, but there are in between kinds of diabetes. We call them as maturity onset diabetes of the young, where the problem is not with insulin deficiency of insulin production, and neither is the problem insulin resistance. The pancreas is able to make insulin, but at the cellular level, there is a little bit of misconnection, and there are different kinds of MODY. It's called maturity onset diabetes of the young. You have MODY 1, MODY 2, 3, 4, 5. There are 5 different kinds of MODYs. So these are patients who may be able to get away without insulin, without medications, but with close watch of their diet, and they do have diabetes, and they do have type 2 diabetes. You're right, kind of MODY is not really a type 1. We call it the 1.5 diabetes. Okay, it's neither 1 or not 2. We put them in this 1.5 diabetes, and yes, you can have. So I don't have Halle Berry, probably has like a, I don't know, GCK mutation, glucokinase mutation, that we can get away without anything. So possible.
Wow. So how do you diagnose that? You said, so how do you diagnose that if they are not in 1 and they are not in 2? So
you know what, you can see them. So if I have let me give you an example. I had a autistic boy who was brought to me because he was found to have diabetes on his annual physical. He was like 18, 19 years old. And his primary doctor saw him and said, oh, you've got diabetes, you're 18, 19, and you've got type 1, and sent him to me. So patients who have type 1 diabetes and they have high blood glucose, they develop osmotic symptoms. So they're thirsty, they're drinking water, they're peeing, they're losing weight. I mean, they are symptomatic. So when you have a guy who's young, 18, 19, not fat, not having any insulin resistance, thin guy, thin lanky guy sitting there, and he says, I'm just fine. The doctor told me my blood glucose is high. I don't have any problem with thirst or thing. Then you start thinking, is this really true type 1 diabetes or not? Or do they have a molecular defect in insulin and glucose signaling that is causing the high blood glucose? So you then suspect, just the clinical presentation makes you suspect. And in this particular boy, you know, he was autistic. He had other congenital anomalies going, and my radar was high. I was not going to label him as a type 1 diabetic, because immediately then you're going to put him on insulin. And how is a poor autistic boy going to manage his life on insulin with carb counting and all that? So I went ahead and did the GCK mutation testing, and then got the diagnosis, and then channeled his treatment, you know, completely differently. So yeah, you just need to have that, the initial diagnosis needs to be done carefully, paying attention to, you know, their clinical symptoms, their BMI, their blood glucose, and all that.
Awesome, awesome. Do we have any other questions out there? Any other questions? Okay.
Can I ask one?
Yeah, go ahead.
Yes, my mom is in Kenya, and yesterday I was talking to her, and she went to see the doctor, and she was advised to start breading her fruits. And she's
Start what?
diabetic. To bread, you know, like breading fruits. Juicing.
Okay.
Juicing fruits.
Uh-huh.
And I asked her, did they tell you like how much, you know, like, and she said, they told me I can eat as much as I can, you know, so that was a little bit, you know, and of course I'm not a doctor in any sense, but I told her, but please be careful, you know, put a little bit of everything, mix with carrots and spinach maybe. But of course, I don't know, what's your advice as far as fruits intake to someone who is diabetic?
First of all, eat whole fruit. There is no need to juice it, because when you juice it, you're taking the pulp, you're taking the fiber, you're taking the solid components out, and you're just extracting the sugar, the fructose part of it. So I would say eat whole fruit. 4 ounces of a fruit. So you chop a fruit, you core an apple, you chop it up, and half a cup is 1 serving. It's 15 grams. So 4 ounces of any fruit is 1 serving of carbohydrate, and take that in consideration with the other carbs that you're going to have with the meal. So you can have about, you know, depending on how heavy the person is, male, female, how bad the diabetes is, you can take about 30 to 45 grams of carbohydrate with each meal. That's what I usually recommend. So they can have a serving of fruit, 4 ounces of fruit, and they can have a second choice of carbohydrate along with protein, or, you know, and any non-starchy vegetables to complete the meal. I think you gave your mom the right advice to kind of mix that fruit with, if she's going to juice, then mix it with the spinach and mix it with, you know, other vegetables, so that she's not getting just a high carb fruit juice, but rather she's getting some more vegetables going in with it. But again, I would question, why juice it? Just eat it.
Yeah, that's the advice she got this week.
Yeah. So I tell my patients, no liquid calories. Let the gut work for it, and have solid carb and have solid food.
So it's advisable too for us also, you know, like even for people without diabetes, you recommend whole fruits versus.
I usually do. Now, I'm not against people who put a bunch of stuff and protein powder and have a smoothie, and people like it, and they like it. It's a matter of preference if they wanted to do that. they're welcome to do that, but it's not something that I recommend. Oh, this is what you need to do.
Okay.
No.
Okay, got you. Thank you.
And to back up what Mary just said, how much fruit, did we talk about that? How much fruit is too much? Because I know when I was, I think when I work in the hospital, I think I see like them recommending like so many grapes, like 10 grapes are serving for, I mean,
Yep.
if you're diabetic, okay.
Yep. So when you look at fruits, the way to remember is F for 4. F is your friend. So 4 ounces, half a cup. And what goes into that half a cup are your fruits and vegetables. So any fruit, if you chop it up and put it into half a cup, that goes for apples, pear, usually half a banana, 15 grapes, 2 plums, small orange, that'll all fit into like a 4-ounce cup. The amount of fruit that you can carry, you can take that accommodates a whole cup are berries and melons. So if you look at berries and melons, they're not very sweet. So you can have a whole cup. So you can have like the cantaloupes and the strawberries and the blueberries. You can have a whole cup, and that's equal to 15 grams of one choice. But all the other fruits, you need to have only half a cup. Now the fruits that are super sweet is really pineapple. Pineapple, that's very high in sugar, very sweet. So you cannot even have half a cup, probably much less than that. And the vegetables that go into the 4-ounce cup is corn, peas, and potatoes. So those are the 3 vegetables that have starch, and you can put them in half a cup measurements, and that will be equal to 1 serving. But the other vegetables like cauliflower and cabbage and carrots and beets, they are also roots. They have a little amount of carbohydrates, but I don't get paranoid about counting those. It's mainly corn, peas, and potatoes.
Very educative. Thank you so much. Wow. Did we have another question? Anyone? We don't want to close anyone out. I know the time is out, but is there anyone with a? Well, if there's no one, I would like to ask you, Doctor, one more thing. What to do? Okay, so if you went to the doctor and they say, you hear this all the time, give us your history. Does anyone in your family has this history? And if there's diabetes in the history, I mean, the family history, then you become in maybe, I would say, high risk, I don't know.
Yep.
What, so how, just comment on that especially as far as faith is concerned, where we also believe that that you were healed, that there's the cleansing, the sanctification through the blood of Jesus. What did you say about that? I'm asking you because I know you're a Christian. I know that the doctors normally I would not be asking this kind of question.
Yeah, so let me paraphrase your question so that I understand it better. Is your question saying, if there is a family history of diabetes, are we doomed to get diabetes, or is faith a very strong component to preventing diabetes from happening? So first, the way I look at it is, if I have a family history of diabetes, God is on my side right away. I have a whole generation ahead of me that's already told me that, hey, there is possibility of diabetes, so I can be more cautious. I can watch what I eat. I can exercise regularly. I can do what I need to prevent myself. I don't believe that Christianity gives us any guarantee against any particular disease. And, I have Christians who have cancer. I have Christians, beautiful Christians with diabetes. And I think it's, I don't necessarily think that having an illness or an infirmity is a sign that we are no longer cleansed by the blood of Christ. That is not true. We do have faith, and we we use that faith to strengthen, to modify our behavior, to do the right thing and to worship him. But then how much do you hold God ransom? How much do you hold God as a spiritual vending machine, right? I want you to give me this because I have faith and I'm a Christian, and you are going to protect me because I'm a Christian and I have faith. I don't know. Tell me, what are your thoughts?
I don't know what everyone thinks, but my thoughts are the same way what you have taught us tonight, that we are the temple. Basically, what you said is we are the temple of the Holy Spirit, and neither the doctor nor we are all work as a team. We are responsible for our own bodies, to take care of our bodies, to take care of the exercise and what you eat, because the God, where there is a trust in God, we believe in God, and I'm one, is actually believing that is that I also know that I take care of myself. Therefore, I turn myself in the gym at least three times a week. I turn myself, and all this because I'm a co-worker with Christ. Because if I stay here, watch TV and popcorns in my mouth all day long, definitely God is not in it. And therefore, I'm going. If I find myself with diabetes, then
Yep, I agree. And so the Holy Spirit propels us to take care of this temple that God has given us, and we hold this body, holy and sanctified before God. At the same time, we don't turn that into an idol and an object to be worshipped. So we draw a balance between the two.
We are finishing. I see a hand there. Is that?
That's me. I think that that's just beautiful what both of you said. I don't want to say on the fence about it, but I think that that's beautiful what you both said. I do believe that when you do come into the body of Christ, that yes, you are cleansed. I think that just to agree with what, and I'm only commenting, Doctor, because you said what was our thoughts. Not to disagree, but when you come into this body of Christ, the Lord already knew what you did with your body beforehand. And I do believe that by faith, God can turn things around for you through prayer and with strong faith. I believe that the whole word, the effectual fervent prayers of the righteous availeth much. But I don't want to say but, I hate using but when it comes down to God, because it's always but God. I believe that you are a temple, and we have to take care of this temple. Just like my sister Eva said, you have to take care of this temple. I don't always do a good job of it. And I just want to say that you were fantastic with this. I do that, and that there are cases that the Lord can turn things completely around.
Absolutely.
Because Jesus is still a healer. He's still the great physician. He's still the lead. And however, we have to realize that it may not happen right away. And that's when it comes to this spiritual vending machine that you're talking about, but you still hold on to that faith and believe that he can heal you, and did heal you.
Absolutely.
Go on that cross. But at that same time, we are going to eat healthy. We are going to stay in that and lift those weights, do what we need to do. So I just want to say you were profound. This was profound. This is profound just hearing you speak from a Christian standpoint, and to correlate the two. Thank you.
Thank you.
So thank you so much. I don't think I closed anyone out. If I say we are done, would I? I told the doctor we have one hour, and now it's going to 20 after, but I know she's been kind enough to listen to us.
You're a great group of women. It's so fun hanging out with you guys.
Is anyone else here? We are good.
Okay.
All right. If we are good, we can close with a word of prayer. Doctor, do you want to pray for us, or
Yeah.
you still have some strength left?
Oh, yes. Oh, yes. My pleasure. Oh, Lord, Almighty Father, we thank you for today. We thank you for this time that you have anointed and you have made this time come to pass. And we know that there are no coincidences, Father. This is intentional. And I thank you for each of these beautiful women who have joined this forum. And I had a chance to talk to each one of them and hear from them, Father. They are beautiful women of God who come together here asking questions, wanting to know how they can use their body and how they can tune their metabolism, use their time, use their resources, use their knowledge, and understand this body that you have given us so that we can use it for the purposes of your kingdom. Father, we know so little today, and we are trying to do the best with the little that we know, but you are the master. You created us. You know every cell in our body, and you hold that ultimate key to our metabolism. But Father, our body is in your hands, and our souls are so much more important. So Father, would you continue to nourish our souls? Would you continue to guide us and to show us the path in which we need to walk? Father, as we ask you for favors and for healing and for miracles and for turning around, would you also remind us the importance of forgiveness, the importance of coming in alignment with who you want us to be before we can expect miracles to happen? Father, would you rejuvenate us from the inside out? Would you give us feet and roots that are rooted in your word and in your love and in your kindness, Father, so that we can reap the fruits that you want us to have? Lord, I thank you for each of these women. I thank you for the knowledge that you have allowed us to have. And we know that what we know is only because you have allowed us to have this bit of knowledge. Would you sanctify us, Father? Would you take what we have? We offer whatever little we have to you, Father. And I pray that you will increase our understanding, our knowledge, our depth, so that we can use it for the purposes of your kingdom. In Jesus' precious and holy name we pray. Amen.
Amen. Amen. Amen. Thank you so much. Thank you so much. Wow. Whew.
Thank you.
Thank you. Thank you for feeding us.
Thank you. That was amazing.
Yeah.